السلام عليكم. Ramadan Kareem. Our lecture today about ileocaecal valve, appendix, large bowel, peritoneal attachment of colon. Ileocaecal valve separates the terminal ileum from the cecum and functions to regulate flow between these two structures and prevent reflux from cecum into the small intestine. The gross anatomy of ileocaecal valve consists of two circular muscular layers of the ileum, an upper and lower lip that are covered by mucosa and protrude into the lumen of the cecum. These folds extend laterally as a frenula. This forms the opening of the terminal ileum into the medial cecum and delineate the upper margin of the cecum and from the ascending colon. So it's at the junction of the cecum and ascending colon. The morphology of the ileocaecal valve, according to endoscopy, either labial type, which is the most common, or papillary type, dome-shaped, or lipomatous, which have a significant amount of fat demonstrated in the lips. This cross-section shows this two horizontal muscular layer, upper and lower, with the lateral extension as a frenula. And this shows how the circular muscle from the ileum protrude to the lumen of the cecum. بس الماوس واضح المؤشر؟ Okay. Radiology of ileocaecal valve. This is barium follow through. This is the ileum and this terminal ileum that's open in the cecum, posterior medial aspect, as a filling defect, which is either polypoidal or bilabed according to the contraction state of the valve. This is the ascending colon. There is a variation in the position, either lateral in 7.5% or posterior in 5%. This is double contrast enema demonstrate a smooth elliptical lesion in the right side of the colon represent the ileocaecal valve. And this is CT scan that show how the ileum open in the ascending colon, and we can easy visible because of fat accumulation in around the ileocaecal valve. And this will be very marked in some individuals, especially in the elderly women. In case of colonic obstruction, there is gaseous distension of the colon. In case of competent ileocaecal valve, so there's distension of large bowel with excessive distension of the cecum with no dilatation of the small bowel. In cases of incompetent ileocaecal valve, there's distension of both large and small intestine without excessive distension of the cecum. At this picture, there's obstruction of the large bowel, dilatation of the colon, and excessive distension of the cecum with no dilatation of small bowel. And this picture shows dilatation of both large bowel and small bowel, no excessive distension of the cecum, so there is incompetent ileocaecal valve. This is X-ray, show dilatation of both large and small intestine due to incompetent ileocaecal valve. Now we'll talk about appendix. The appendix arises at the convergence of the tinea coli of the posterior middle wall of the cecum, about 2.5 cm below the ileocaecal valve. As this picture shows, this is the ileocaecal valve, 2.5 cm below it, the opening of the appendix in the cecum. It is thin structure containing lymphoid tissue, variable in length between 12 to 24 cm, having its own mesentery. This is the mesentery, which is a triangular fold that extended from the lower border of ileum, so the appendix will be mobile. The lumen of the appendix is wide in the infant and obliterated in mid-adult life, so acute appendicitis, which is usually caused by obstruction of the lumen, is rare in the extremities of life. The appendix is supplied by appendicular artery, which is a branch of the ileocaecal artery. We see this is appendicular artery, arises from ileocaecal artery along the appendicular mesoappendix. So if there's infection, will causes thrombosis of this artery, so gangrene and perforation will be result. In contrast to other organs like gallbladder, which have a rich collateral of blood supply, so not easy to result in ischemia and gangrene and perforation. Lymphatic drainage of the appendix is to paracolic node along the ileocaecal to the SMA group. Variation in position of appendix. 64% retrocecal, 35% inferior medial, 0.5% post-ileal, and other possible positions, pelvic, periareal, and subcecal. The location of the appendix has wide individual variability. It can be found at the McBurney point, or can be found from groin to the umbilicus, or even higher in the liver, and it's rarely in the left side. Radiological feature of normal appendix. Plain abdominal fin. Fecal or fluid level of appendix may be seen in normal people about 10%. This X-ray shows fecal in right iliac area, and this if you see 90%, is acute appendicitis. Ultrasound. This is the appendix. We show this is diameter mallet less than 6 mm. This is longitudinal picture. Should be one of the feature of normal appendix of ultrasound. It will be blind-ended, show peristalsis, diameter less than 6 mm. The position is variable, and use compression by ultrasound probe to reduce obscuring gas in the overlying bowel and push overlying bowel lobe. CT scan feature of normal appendix. It usually arises posterior to the cecum and may have a long and tortuous course. The feature of normal appendix in the CT: normal caliber less than 6 mm, preserved periappendicular fat, and intraluminal gas or a contrast. The appendix commonly lies behind the cecum, as this axial CT shows the appendix behind the ascending colon. In this picture, also we see the appendix with thin wall and homogeneous non-inflamed fat posterior to the ascending colon. And this picture, we show the appendix higher in level, at the level, tip of the appendix at the level of right liver lobe. This is coronal CT, show the appendix at the level of the right liver lobe. So if patient develop acute appendicitis, the maximum area of pain will not be in the right lower quadrant. Appendicitis is inflammation of the appendix. Is very common condition in general radiology practice and is one of the main reasons for abdominal surgery in young patients. The classical presentation is very umbilical pain, which within a day or later localized to McBurney points with associated fever, nausea, vomiting. This progression is only seen in a minority of cases and is unhelpful in children, who is often presented with vague and non-specific signs and symptoms. It also relies on the appendix being in a normal position, which is not the case in a significant number of cases. Appendicitis typically causes by obstruction of the appendicular lumen, which is result in buildup of fluid, suppurative inflammation, secondary infection, venous congestion, ischemia, and necrosis. And the obstruction caused by lymphoid hyperplasia in 60%, appendicular in 33%, and foreign body in 4%. Ultrasound criteria to diagnose appendicitis. It's blind and tubular structure, non-compressible, diameter more than 6 mm, aperistatic and echogenic inflammatory periappendicular fat, the wall thickness more than 3 mm, appendicular casting acoustic shadow surrounding fluid or abscess, edema of cecal pool. This is ultrasound. This is transverse and longitudinal. Show the diameter more than 6 mm, the wall thickness more than 3 mm. There's fecal. There's increased echogenicity of the surrounding fat. This is another picture. Show the appendix with more than 6 mm. CT sign of appendicitis: an appendix measuring more than 6 mm, failure of appendix to fill with oral contrast or air in its tip, enhancement of its wall with IV contrast, and appendiculate. Surrounding inflammatory changes, which include increased fat attenuation, fluid, inflammatory phlegmon, cecal thickening, abscess, extraluminal gas, and lymphadenopathy. This is a case study. This is 18 years old male patient presented with sudden onset of right lower quadrant pain and rebound tenderness. This CT shows mural thickening of the wall of the cecum. This is thickening of the wall of the cecum at the base of the appendix. In the next picture, which is more caudally, We show normal distal ileum opacified. This is the ileum opacified by contrast material. The arteries opacified densely with IV contrast, while veins still not yet become opacified. The vascular will enteric contrast aid in distinguishing normal structure from non-opacified lumen of the appendix. This is more caudal section, show the inflamed appendix. This is the inflamed appendix, and enlarged lymph nodes. We show the enhancing thick wall of the appendix and infiltration of the surrounding fat. This is coronal picture. Show thick wall appendix. This is the appendix thick wall adjacent to the ascending colon and adjacent to the psoas muscle. In patients with acute appendicitis, the psoas muscle is often inflamed, that causing pain when the leg is flexed and striating. This is other coronal section. The wall of the cecum is thickened, that is due to inflammation from contagious appendix. Appendicular abscess. Abscess formation is one of the complications of appendicitis following rupture of inflamed and distended appendix. The appendix is on a mesentery and mobile. Pus from the infected appendix may cause abscess formation in a variety of locations. The pus may extend inferiorly to the retrovesical or retrouterine and superiorly to subhepatic area. This is the appendicular abscess. Now we'll talk about large intestine. The large intestine is variable in length with average length of 1.5 meter and variable in diameter, with large diameter in the cecum about 9 cm and the transverse colon 5 cm. This is part of the large bowel, which is the cecum and the appendix open in the posterior medial wall. Ascending colon, this hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid, rectum, and anum. The large bowel is marked by 3 flattened band of longitudinal muscle called the tinea coli. The tinea coli are shorter than the colon, about 30 cm. So lead to formation of circulations, which gives rise radiologically to the appearance of incomplete septa, which is the hastara. Appendicular epiploica, appendices epiploica are fat-filled peritoneal tags scattered over free surface of large bowel, except in the cecum and the rectum, and more numerous in the sigmoid colon. We'll talk about diverticulosis. The arterial supply of appendices epiploica perforate the muscle wall. So mucous membrane may herniate through these vascular perforation, give rise to diverticulosis. Development of the colon. In the 5th fetal week, the midgut herniate into the umbilical cord with a vitellointestinal duct at the apex of the hernia, at this picture. At the 10th week, the loop of the gut returned to abdominal cavity, proximal bowel before the distal bowel, rotating 270 degrees anti-clockwise. This results in the jejunum being on the left and deeper than the colon, and cecum being on the right and superficial. This is the rotation, and this will complete. So this is the colon, and this is the cecum. In malrotation, the bowel return without rotation of small bowel lies, without rotation, so the small bowel lies on the right and the colon will be on the left. In this case, this omphalocele, this is midgut herniation to the umbilicus, which persists at birth. Radiology of large bowel, this is abdominal X-ray, this is adult AP radiograph. We show this is the cecum, this is the hepatic flexure, this is splenic flexure, and this is gas in descending colon. Air contrast barium enema. In this case, we show the transverse colon and sigmoid colon. So this position is prone, which is show the most dependent part, which is transverse and sigmoid colon. And this is the hepatic and splenic flexure. It will be separate between retroperitoneal and the intraperitoneal transverse colon. Air contrast barium enema. In supine position image, this is supine. Show the barium pools in the ascending and descending colon as well as in the rectum. Colonic transverse folds are spaced farther apart from those of small intestine, a useful marker in distinguishing among bowel segments in on-plane radiograph. CT colonography. This is segmental view, show the entire colon distended well with gas. This is second picture, show and this is portions of the colon, and as we see pointed here, there's a polypoid structure which contains of low density content, so there is fat content. And CT analysis show the same lesion. This is axial CT scan, show at the level of L2, L3. We see this is the ascending colon, this is the transverse colon, this is the descending colon, and this is the ileum. MR enterography, show this is the ascending colon, this is the hepatic flexure, this is the splenic flexure, this is descending colon, and this is the sigmoid colon. Large bowel, blood supply, venous drainage, and lymphatic drainage. Blood supply of large bowel is by two arteries, superior mesenteric artery and inferior mesenteric artery. Superior mesenteric artery for blood that derived from midgut, from cecum to the proximal two-thirds of transverse colon. The branches of superior mesenteric artery, ileocaecal artery for cecum, appendix, beginning of ascending, right caecal artery for remainder of ascending, and middle caecal artery for transverse colon, the proximal two-thirds. Inferior mesenteric for part that derived from hindgut, from distal one-third of transverse colon to the upper rectum. Branches left caecal, sigmoid, left caecal for descending colon, sigmoid for sigmoid colon, superior rectum for upper rectum. This picture shows the superior mesenteric artery and its branches. This is the ileocaecal, which is lowermost, that's supplying cecum and the beginning of the ascending. And this is the right caecal that's supplying the rest of the ascending colon. And this is the middle caecal that's supplying proximal two-thirds of the transverse colon. This picture for the lower mesenteric artery for part that derived from hindgut. The first one, left caecal, supplying distal one-third of transverse colon and descending colon, sigmoid for sigmoid colon, and the superior rectal artery for upper rectum. In this picture, we show there's anastomosis between the branches of superior mesenteric artery and inferior, resulting in marginal artery of Drummond. So the blood supply of the large bowel is end arteries, which may be deficient in the area of connection between the superior and the inferior, between the part of the midgut and the hindgut, which is splenic flexure. So it is available for bowel ischemia. Venous drainage follow the superior mesenteric and inferior mesenteric. Superior mesenteric vein will go to the portal of the circulation. Inferior mesenteric with celiac with splenic vein to portal circulation. Lymphatic drainage is also follow the mesenteric vessel, superior and inferior mesenteric artery. This is CT angiograph that show the aorta, which is its branch. This is celiac trunk, and this is superior mesenteric that derived at the level of L1, just below about 2 cm from celiac trunk. And this is the inferior, inferior. It's called inferior at the level of L3. This is angiogram of the superior mesenteric artery and its branches. Right, this is the middle caecal, and this is the ileocaecal artery, which is give both ileocaecal with right caecal. This is the left caecal, sigmoid, and this is superior rectal. This is angiogram of inferior mesenteric artery, giving left caecal and the sigmoid branches and the superior rectal artery. This is an ultrasound case, show the aorta, at first given the celiac trunk, which is given splenic artery and hepatic artery. This is the Siegel sign, and this is the aorta of the list level given superior mesenteric artery, which have a relation to become behind to the neck of the pancreas and splenic vein. Peritoneal attachment of large bowel. Ascending with descending colon is retroperitoneum that covered anteriorly only by peritoneum. The peritoneal space is lateral to these to the ascending and descending colon called paracolic gutter, which act as a route for transmission of infection in the peritoneal spaces. Cecum is intraperitoneal, transverse colon is intraperitoneal and has own mesentery mesocolon. Splenic flexures attached to the diaphragm by phrenicocholic ligament. Sigmoid colon is intraperitoneal, has its own mesentery, also has its own mesentery. The rectum upper third covered anteriorly and laterally by peritoneum. The middle third only anteriorly, with lower third free of peritoneum. This is the picture show the peritoneal spaces, and this is this is parts of large bowel with its mesentery. And this picture shows the small bowel mesentery, and this is the greater omentum, and this is the sigmoid mesocolon. This is the appendix mesocolon. I'm sure this is the transverse colon. And thank you for your listening. نبدأ دكتور الكويز.
خلينا نشوفك واحد عنده سؤال على قبل ما نروح للكويز. طبعا هي المعلومات اللي ذكرتها كلها مهمة، لأنه تعرفون انتم يعني الابدومن والبول كلها أشياء مهمة وكلها بيها ديزيزز وهاي، فما بيها فد أشياء يعني زايدة أو هذه، فهذه يعني تنحفظ حفظ كامل يعني وتنعاد أكثر من مرة لأنه كلها مهمة، الأبندكس والكولون والفاسكولاريتي أوف ذا كولون أوكي. إذا نروح على الكويز، يلا سما.
أوكي.
خلينا نختار تمارا.
نعم أستاذ. رقم 1 الأسندنج كولون.
ولو بصراحة هي الصورة شوية مطولتها ومو كلش. إيه. هو شنو الفحص هذا تمارا؟
هذا سيتي sagittal reconstructed CT image.
sagittal هذا تتوقعي؟
هو هذا دكتور الإليوم مبين.
اي اذا الإليوم مبين
يعني لا عفوا الإليوكبون، اقصد الإليوكبون مبين. sagittal مو هي صورة مو كلش واضحة.
لا sagittal الإليوكبون يبين تمارا.
كورونا.
كورونا.
العفو الدكتور كورونا الاسفه كورونا
شويه بيوبليكويتي، بس شويه بيوبليك. حتى الريكتايل اوبليك والميدل
نعم.
والسوبرفيشال والديب.
كورونا ريكونستراكتد سي تي ايمج.
اوكي. اذا هذا الرقم 1 قلتي
الاسندنج كولون.
اوكي.
نعم استاذ. رقم 2 السيكم.
2 السيكم اللي هو بلو أحمد طالب. رقم 3 مرتضى.
نعم أستاذ. رقم 3 الأبندكس.
هذا الأبندكس طبعا شوية هنا همينه elongated هو وطالع from the cecum إذا تلاحظوا in continuity. بس صارت تأشيرات عليه مال رقم 4، فهو المفروض يبين بلايند سؤدة سلمان رقم 4 مشرت لك عليه.
إليوم. This is the ileum.
Which part of the ileum تتوقع؟
Terminal
ileum. اوكي. بقى لنا رقم 5 دكتور عزام.
نعم استاذ. هاي الإليوسيكال فالف.
بالضبط الإليوسيكال. ايش كم تعب عندنا إليوسيكال فالف according to the endoscope عزام؟
والله استاذ ما اعرف يعني.
قالتها بالمحاضرة. الليبيال تايب اللي هو
استاذ بوليبويد والبايلايتر.
اي البوليبويدال والليبيال تايب والفاتي هذا. اي
استاذ.
اوكي ثلاثه.
نعم
هاي يشوفوها للاندوسكوب مو احنا. اوكي شكرا جزيلا. بعد استاذ محمد يكمل. عندك بعد مو؟
اي دكتور.
يلا استاذ محمد.
مروان رقم 1.
So this is a cecum.
وشنو الفحص هو هذا؟
باريوم انيما استاذ.
Which type مال باريوم انيما؟ How many type of باريوم انيما عندنا؟
With air contrast.
يعني؟
With air استاذ. Air contrast.
هذا دبل كونتراست. سنجل ودبل كونتراست.
دبل كونتراست.
الوضعيه شلون ماخذيها هاي يا مروان تعرف؟
برون استاذ.
الوضعيه شلون ماخذيها؟
برون بوزيشن.
هاي اوبليك. اذا اشوف شو اسمه اوبليك فيو.
البون صحيح استاذ.
رقم 2 هدى.
نعم أستاذ. APPENDIX.
APPENDIX. رقم 3 ياسمين.
نعم أستاذ.
رقم 3
قالت سيبلينيك فليكت.
رقم 4 عماد.
استاذ descending colon.
زين بعد عندك شيء؟
لا هاي هي دكتور.
بس عندي سؤال اني